Hello. For those of you who don't know me, my name is Dr. Kathy Craven. My home base is here in Toronto at the Linter Centre, a part of the University Health Network, affiliated with the University of Toronto. This is the first in a series of podcasts created by members of the Canadian SCI community for members of the SCI community. This first podcast addressed common questions about COVID and respiratory impairment and features my colleagues and friends from Edmonton, Alberta, Winnipeg, Manitoba, and Hamilton Health Sciences. We hope this will help to address your needs during the COVID pandemic.
Hello, my name is Christine Cowley. I am a researcher at the University of Manitoba, and I'm also a former executive director of SCI Manitoba. And today I'm going to be serving as a commentator or questioner for our group, which is representing the Canadian spinal cord injury community. And our interest today is in looking at some respiratory care in the post-COVID-19 situation. And the next to introduce themselves.
So I'm Graham Jones. I work in the intensive care unit, specifically the COVID unit right now. Plus I have been in the last 15 years, I've been looking after people with various neuromuscular disorders requiring respiratory support.
Hi, I'm Dr. Janice Richmond Eisenstadt. I'm a lung doctor specializing in people with neurological conditions that can or do affect their breathing. So that includes people with spinal cord injury. I work at the University of Alberta and the Glenrose Rehabilitation Hospital in Edmonton. And my focus is keeping people at home.
Okay, my first question would be to either of you, but I think what I'm going to do is ask these questions based on being at a different level of spinal cord injury, because I think the recommendations and advice that you might have might change depending on the person's level of injury and whether or not they currently actually use respiratory care or don't. So, for example, if I were a person with a C4 spinal cord injury and was on ventilator assistance for a good portion of the day, I guess what I'd like to know is whether or not I'm at risk or increased risk of getting COVID because of using because of having respiratory care. And then secondly, whether or not I'm at increased risk for developing severe complications if I do develop COVID-19.
Okay, well, I can go first. The risks of developing the infection aren't really related to any comorbidities. If you do have a spinal cord injury, you might actually be protected because you might not be able to touch your face. And that's one of the ways these things get transmitted. So I suspect that's not a big deal. You have to do the same precautions that everyone else does. Physical distancing, washing your hands, not touching your face. And religious washing of hands. I think a lot of this virus is transmitted by getting in touch with the droplets. Once you get it, though, another story. I mean, we know that people with significant health issues, not of any type, can be potentially get more serious disease. But that doesn't. It's a difficult question to answer because the majority of people will get the virus and it will not cause any significant issues. There will be a percentage of people that will have significant disease requiring hospital admission, and the worst case is that you require ventilation in the ICU. Once you get to that point, people are pretty sick, and people with significant health issues, and I would think spinal cord injury would qualify for that, are less likely to survive the treatment. So the majority of people, it won't be a big deal, regardless of your health, but it can certainly, in a small percentage, and we don't know what the percentage is because the numbers are, basically what we're looking at is number of positive tests. We don't know how many people are out there that have the disease that don't have been tested. So it's hard to quantify.
So that brings up an interesting question then. So regardless of whether, for clarification, I'll ask this, regardless of whether or not a person has a comorbidity, whether it's obesity or high blood pressure or type 2 diabetes or spinal cord injury, the majority of people, even with those comorbidities, are you saying then are not necessarily going to develop a more severe form of the disease?
Yeah, no, it's not. There's no absolute. So I mean, as the more strikes you have against you, let's say, you know, the more likely you are to have serious disease, but it's not 100% by any means. And the majority of people, I still think, would have relatively mild disease. It's the case.
There are two. Excuse me. I'd like to add there are two issues here, Chris. One is your risk to catch the disease. And your risk of catching the disease is like anybody else, based on exposure, contact, touching your face, and so as Graham said, the three main things are keeping your hands clean. But if you're a high spinal cord injury, then it's your caregivers keeping their hands clean, you and them not touching their face, and you and them practicing social distancing. Of course, if you are a high spinal cord injury, you need your caregiver to be close. So again, it's a matter of, if they're always in your house or your home, that's a difference. That's one thing. If they're coming in and out, then you have to be extra cautious and paranoid almost about the washing of hands, and soap. This is the best thing. Alcohol on your hands is not advised, nor is bleach on your hands. That's for surfaces. So hand washing of your caregivers, not touching your face, and them frequently washing their hands before contact with you, after contact with you. And the other key thing in terms of helping prevent catching this, especially when you have people coming in and out to look after you, is careful cleaning. Sanitizing all common surfaces, your phone, your wheelchair, your computer, the keyboard, your wheelchair, all surfaces that your caregivers touch should be wiped down regularly. So that addresses one thing in terms of catching it. So you reduce your risk if you stay safe with these three measures of careful hand washing, avoiding touching the T-zone of your face or the caregiver's face, and social distancing and wiping things down. The second issue, as Graham said, is, well, if you do get sick, could it be worse? Well, yes, if you have certain comorbidities, they have been associated with a worse disease. But again, 80% of people have a mild form of disease. And if you do have a mild form of disease, then you may need to take different precautions if you're mild and you stay at home. You definitely want to keep in touch with your respiratory therapist, your family doctor, your specialist, your home care nurse. And then there may be additional precautions, so that if you are someone who's on BiPAP or you're invasively ventilated and you are frequently suctioned, or you're on lung recruitment, or you're on a cough assist, these are things that are aerosol generating medical procedures. And then you want to keep your caregiver sick, because if your caregiver gets sick, who's looking after you? So that would be the next level, that then you need your caregiver to keep safe, wash hands. They will need a mask, and how they get masks, you'll have to check with your local community. And eye protection for those aerosol generating medical procedures that keep you healthy in your home. And certainly if you do get sick, you're more likely to need more of your supports of breathing with your BiPAP or your ventilator, with your lung volume recruitment to help you cough and clear, or your cough assist to help you cough and clear. And since those are aerosol generating medical procedures, having a mask will help.
would you recommend if someone doesn't have a situation where they are generating aerosols in their day-to-day life, but they do require home care, would you recommend as a protective measure that their home care worker, when they come into the home, wear a mask just to be on the safe side, in addition to all the practices that you had mentioned, just because we don't know whether or not they might have had COVID or they might be exposed to it?
So there's still several things that we don't know about this new disease. One is we don't fully understand to what extent people who have been infected but don't have symptoms, to what extent they're contagious, they're infectious, to what extent they can give this to you. Certainly wearing a mask, the most important thing about wearing a mask is as an aid to stop touching your face, because we touch our face 20 to 40 times an hour. It's just our human nature. And for me, as someone who talks with their hands, I'm constantly touching my face. If you wear a mask, the idea is you use the straps. You don't touch the mask itself, and that could help someone else from touching their face and contaminating you. Or if they have a little bit of a sniffle, that could be, snow mold or allergies, or maybe it's a bit of the disease, or maybe it's the flu or other causes of colds like rhinovirus. That should help them be less likely of sharing that with you. However, there are a few people who are telling me that wearing a mask causes them to touch their face more. In that case, they shouldn't. But again, there's this balance of people, caregivers coming to work who may be mildly under the weather, but can protect themselves and protect you. And that person who's mildly ill not coming into work, and then who's looking after you. Because while the healthcare organizations in each province are very actively looking at, their focus is the emergency room, the acute care, hospitals, there isn't much attention being paid to how do we help people who are mildly ill stay at home, and what do we do if their caregivers don't show up for work? Do they have backup plan? Do they have family who can fill in? Do they have a big enough roster of care providers that someone else can substitute? So yes, a mask can help, but again, it's that how sick are they? How likely are they to share it? Are they well enough to work? And are they following procedure? Washing their hands frequently, not touching their face, staying away from you except for absolute necessary interventions. And then for those, for sure, they wear gloves, wear a mask. But again, you'll need to be washing your hands before putting the gloves on, washing your hands after they put take the gloves off. And the same thing, knowing which order to put the gloves and the face mask on and off. And this is where your home care supports, your home care nurse or your case coordinator can help.
Is there specific information regarding those types of techniques that people with spinal cord injury could access in terms of having that knowledge if they're using, say, self-managed attendant care, or do you think that information is available already in the hands of the caregivers?
There certainly are some very good videos available for donning and doffing the personal protective equipment. There's a very good one from the NHS in England about the order that you put your gloves and masks on and things like that. So there's and that's just one. I'm sure there are hundreds of those sorts of videos. There are probably too many, right? So it would be we will give recommendations about which is the better ones, perhaps.
I think one of the best videos that everyone should be reviewing now in terms of people with spinal cord injury and their caregivers, both formal and informal caregivers, they should be reviewing good hand washing technique. And there are several great hand washing videos. My favorite one currently is the one by Alton Brown, who's the science chef, but there are several others. And I'm sure we could post or share these with each other. How to stay safe. I think this is good to be reviewed by the case manager, your home care case manager, in the context of your particular situation, your particular home environment, and your particular caregivers.
Thank you for that information. I guess one of the things would be moving forward, this virus is going to be around for 18 months to 2 years before we're in a stage where we might have developed some sort of herd immunity, or even a vaccine if we get to that point, or other situations where we wouldn't have such severe disease in certain cases. But there's a fine balance between being careful and also, you know, we're going to have to be living our lives in the future. It's early times right now, and we're now in a stage where we're still, you know, staying at home and trying to slow the rate of rise of this disease. But what's the balance between, you know, living in your home, living with your family, and the situation that might be different if you do have a lot of traffic in and out of the house because you have home care, but then there's also probably 40 to 50% of the population with spinal cord injury who don't have home care. But what would be the advice that you might give them in terms of just general cleanly practices as it relates to not developing disease? And I'm not, as I ask the question, I'm thinking it's maybe not necessary to answer that in any other relationship more than what we've already done. So maybe we should just nix that one.
Other than to say we're developing a new normal for the pandemic now, and what our new normal will be as things tail off, we don't know. We don't know. I put my hope in and faith in people following the advice of public health now, keeping ourselves, our friends, and our families safe, staying connected virtually. Thank goodness for the technology we have now. During the polio epidemics that were recurrent, everyone stayed home and they didn't have access to phones or video chatting or email the way we do now. But I do see a new normal because these same procedures are going to keep us safer for when it's the next winter and it's flu season or it's cold season. Time will tell, and hopefully we will have an effective vaccine in the near future, that just like we have a flu vaccine every year and we have access to the pneumonia vaccine. So I think it's hard to predict the future, but let's keep safe now and have faith in a new normal for when this settles down.
Is there any advice that you might give if a person does develop symptoms of COVID-19 that are specific for different levels of spinal cord injury?
At this point, I don't think it matters because there I was touching my face again. This is, we've got a 45-year-old perfectly healthy male in the ICU right now, intubated and ventilated. So I don't think it matters, about you getting it. And everyone has the potential for getting sick. The question is you have symptoms, and the big symptoms, which we haven't really talked about, would be a cough with no sputum and fever, are probably the big ones. And out of the UK, smell seems to be, if you lose your smell or taste, that might be a clue. Because these things in springtime, you've got allergies, you've got other viruses, you've got all sorts of things. So it's actually very difficult to say, yes, you've got COVID. So I think you assume you have it. And that's the idea of all of the preventative strategies are to sort of prevent you from getting it. Once you've got it, I mean, again, likely going to be a mild disease. The question is what do you start doing once you're not tolerating what's going on, right? So once you start really getting short of breath, perhaps your oxygen levels are dropping, and things like that. Yeah, the question is, when we know that going to the hospital is potentially bad, so it's a difficult situation. And one of the things we're trying to figure out here is when you should go to the hospital. I don't have a good answer.
So then the next question, I guess, would be if a person does develop COVID and they do start to develop more than just the minor symptoms of a dry cough and some fever, what are the signs to watch for in terms of whether or not a person should seek further medical attention?
Well, the trigger for us is what's your oxygen level. So the people who get severe illness have severe hypoxemia that doesn't respond to supplemental oxygen. So I think knowing what your oxygen levels might be helpful. Oximeters are relatively cheap. You can get them at just about every drugstore now and Walmart. So I think if your oxygen levels are dropping, that's important. We may even be able to organize home oxygen for you, depending where you are. I mean, in Ontario, we can certainly do that. But I think that's where you're going to have major problems with the illness, is that your oxygen levels are low and that your oxygen is clearly important. So that's when you would need assistance, either with supplemental oxygen, and then if the supplemental oxygen doesn't help, those are the people that end up being intubated and ventilated.
So I'd like to address question 1, the prior one about if you're not feeling well at home. So first of all, there's several things you can do. If you have a fever, take medication to keep your fever down and to feel well. A lot of people describe muscle aches. Tylenol can help with that. Stretches, staying warm. You may find that you might need your inhalers more frequently. You may need more lung volume recruitment or cough assist. You may need more time on your BiPAP or your ventilator if you're someone who tends to use your breathing support only at night or for naps or rest periods during the day. The other thing is to make sure you're keeping up with your fluids. You do not want to get dehydrated. You want to keep up with your fluids so that you feel good. If you have nasal symptoms, address those with saline nasal irrigation, saltwater sprays. If you have a drip, take care of that, because this is sinus issues and nasal issues are things that will make you feel more breathless. And if you aren't feeling well, contact either your family doctor or your home care respiratory therapist if you have one, or your respirologist for further advice, and also your home care case coordinator, so that they can arrange for maybe a nurse to call and check in on you, or your home care RT to call and check in on you. Know if you are feeling more breathless and you're still feeling breathless on your breathing support, it may mean that your machines need adjustment of their settings. So this is something that can be done in the home and sometimes remotely if you're on certain BiPAP machines. This can be done with an order from your doctor to your vendor respiratory therapist. And then it's a really tough question. When do you go to hospital? I think the first thing you need to know is, what are your wishes if things get worse? Because you might be like 80% of the population and have a mild illness. But if you don't have the supports that I talked about with the breathing support, lung volume recruitment support, cough assist support, medications in the home, or ready access to medications in the home, then you might not have any option but go to the emergency room. But that's, again, if you are okay with getting more aggressive support. And more aggressive support might mean just supplemental oxygen. But again, if you have all these other supports, home oxygen can be arranged pretty readily in the home. The challenge will be, do you have a home care RT that has access to the personal protective equipment to go into your home and set you up? Or will the vendor RT have this access to this equipment to set you up? These are things I'm looking into in advance to know who's available to help my patients if they just need some supplemental oxygen and some tweaking of their settings in the home. But it's really important that you know now, and we should always know at all times and frequently review, what are our wishes if we get sicker? If we aren't invasively vented, are we okay with being invasively vented? If we get really sick and there's a high chance of us dying, what what do we want that to look like? Do we want do we want that chance? But keep in mind, if things get really bad, you're not going to have your caregiver or family or friends able to be with you. You're going to be alone. And if that's when it's your time to die, you'll be dying alone with healthcare providers who will be doing their best to support you emotionally as well as physically. But it's not the same if you think, okay, you know, I've had a long enough journey in my life or with my spinal cord injury. If I get seriously ill, you know, I don't want to be isolated in the hospital, in the ICU. I would prefer to be at home. And if it's my time to die, then I would like palliative home care supports. I have been asked by some of my patients, well, if I have no one to look after me and I'm really bad, I don't want to be choking or gasping or suffering at the end of my life, but I don't want to go to hospital. I don't want to be in an ICU. I don't want escalation of care. Does this mean I have to ask for MAID, medical assistance in dying? And I'm reassuring everyone that no, this is not a time for asking for MAID. This is a time to understand that there is palliative care support and methods, and I've got all sorts of tricks up this sleeve and more up this sleeve of how to keep people comfortable in their home. The key thing is, will you have a caregiver to support you? And I'm in the process of checking with my palliative care colleagues. Are there hospices that will be able to support our patients at end of life if it comes to that during this COVID epidemic? But I do believe you need to know, what are your wishes? What do you want? What do you not want in terms of care? Where do you want to be? Where do you want to be looked after? And if you can't speak for yourself, who's going to speak with your voice so that the healthcare system, know how to support you through this pandemic or at the end of life, whichever it is. And that should be done regardless of this pandemic or not. And the bottom line is, you want to fulfill your wishes. You don't want to do things you don't want to do. And if you have not defined this, then things may go in a direction you don't want.
That's a very thorough evaluation of the different questions that need to be asked. In fact, it's probably quite relevant for anybody, regardless of whether or not they have a spinal cord injury or not. So, you know, those are some very important questions to address and to think about. And it gets at this whole concept of, whether or not you want to go to the ER, what that could mean potentially. If it gets better, great. But if it doesn't get better, what are you going to do and how do you want to end your life on this earth? And then before that point, though, is assuming that you are going to the ER, one question that's sort of intermediate there. We've dealt with the end of life and how you want to, what you want to be surrounded by at your end of life. So that's a very serious matter and that needs to be considered. And then, if you go to the ER and you are supported and you live, that's good and that's great and that's the outcome that, of course, everybody would want. There's an intermediate step there, because if you are having to go to the ER, what should a person bring if you do have to go to the ER, and what will the situation be like if you are going to the ER? So I know that you had already said that you won't be surrounded by family or caregivers or anyone that you know, but are there any essential items that people need to think about to bring if they're going to the ER?
Bring your equipment. If you're on a ventilator, bring your ventilator. If you're on a BiPAP machine, bring your BiPAP. If you've got a cough assist, bring your cough assist. If you've got a lung volume recruitment bagger, bring it. One of the difficult situations, and maybe Graham can speak to this, is these are all aerosol generating medical devices. And if you are feeling more breathless, you should be transported while you're on your breathing support. If you're trach invented and you have a cuff tube, then that's easy for paramedics. Your caregiver can inflate the cuff, and then there's less risk to the people around you. If you have a active, depending on what kind of ventilator and circuit you have. If you are more breathless and you need to be on your BiPAP, you or your caregiver will have to explain to the paramedics that you can't come off your BiPAP. And the emergency rooms don't want these aerosol generating medical devices to be used in the emergency room, yet how are you going to breathe if you don't have them and you're feeling more breathless? Because it's not just a matter of your oxygen levels. Is there a device? Do you have the device that allows the paramedics to tee in oxygen into your BiPAP if you're not already on oxygen? Is there a way that you can notify the paramedics in advance to say, I'm on BiPAP and I need to stay on BiPAP? There have been some cases where patients with spinal cord injury or neuromuscular disorders who are dependent on their BiPAP, they get sick. This is before the pandemic. And paramedics who don't fully understand the difference between ventilation support and CPAP will want to take you off your BiPAP and put you on CPAP. And it has to be clear that this is dangerous and they're not to do this. So any way that you can have this documented in, your green sleeve or, the sleeve with all your goals of care, your personal directive, the list of your doctors and the medications, and maybe a letter from your doctor or your respiratory therapist. If this patient needs to be transported, they need to be transported on their BiPAP. Paramedics need to come in, personal protective equipment, and we need to inform the emergency room in advance. What I like to do is know who's getting sick and who's heading to the emergency room, so I can call in advance, call them and my ICU colleagues and say, hey, my patient's not doing well and the paramedics are in the process of bringing them in and they're on BiPAP. So they're going to have to bypass Emerge, or Emerge is going to have to be ready to take them directly into a protected room. And I think this is why if you have equipment and you can be looked after at home, that would be great, but that's not going to work for everybody. There will be situations where you're not feeling well. You need the assessment, the monitoring, and the closer care, especially if you want heroic measures and the chance of getting through this. And keep in mind that you might be sick from something other than COVID-19, for which you'll need to go to the emergency room, just like you would go if there wasn't a pandemic. But we've got COVID-19 on the brain.
So right now, if you showed up to the emergency room requiring ventilatory support, we would not use the BiPAP. We would intubate you. And that would be it, because it is an aerosolized, it's an aerosol generating procedure, and it's in terms of the safety of everyone. We're not using BiPAP in the hospitals whatsoever. We don't even use high flow nasal cannula because of the risk of generating. Now that may change. And if you look at a lot of the photos coming out of Italy or the videos from Italy, a lot of them are people who are on BiPAP. So, but at this point, we're not using BiPAP in the hospital at all. If you need ventilatory support, it will be invasive ventilation.
So does that mean that the paramedics are going to intubate you in your home and then transport you?
I do not know. I don't think it's been tested yet. If you're, I doubt they'll be very uncomfortable transporting you with BiPAP because it is an aerosolized generating procedure in a tin can, essentially. So it's one of the principles is trying to protect the healthcare workers as much as we can. And at this point, people, the policies are fairly clear that non-invasive ventilation should not be used. Now it's difficult.
I have several patients who are non-invasive ventilation. If they stop their BiPAP, they don't breathe.
Yep. And that's
particularly true for a sick person with high spinal cord injury.
Now, at this point, so the COVID stuff, what we're trying now is trying to avoid overwhelming the healthcare system. So we haven't fully saturated, which is what's happened in New York, right? They fully saturated everything they can do. When that happens, we have to start deciding who gets the ventilation and who doesn't get the ventilation. And at that point, anyone with any significant chronic illness, a spinal cord injury, I'm not sure about, but certainly any of the sort of chronic neuromuscular illnesses would not even get considered for ventilation. It would be a so at that point there's no value in going to the hospital. It's only going to make things worse. And if you're already on a ventilator at home, you might be better off staying at home and taking your chances. But that's the absolute worst case scenario where we're just now there's it's like we're talking about hundreds of people on ventilators in the hospital. And hopefully it doesn't come to that. And that's one of the, I was going to mention this earlier, one of the things we're trying to do with all this physical distance is we're probably not going to change the cases as much, but we're spreading it out so we don't saturate the healthcare system.
And then
Those are important points as well that we need to think about, really.
I was just going to add that this is a time then that vulnerable patients really need to define their goals of care, what they want, what they don't want, and to know who to call in case they're declining, in case they're feeling worse, so that support from their doctors, nurses, respiratory therapists, and their pharmacists can help them either get through this at home or help them pass away comfortably and peacefully in their home.
Because it could be that going to hospital is actually going to make everything worse. Whether you get better or whether you don't get better, it's going to be you're going to be like we said. There's no visitors. There people are going to be aggravated with you because you're using an aerosolized generating thing. No fault of your own, of course, but that's the sort of policy. At this point, we're not there yet because we still have fairly good resources, but to my knowledge, where the use of BiPAP is being severely curtailed. It's very difficult to say someone actually doesn't have the COVID. We're finding out now that the negative swab isn't overly. There's a significant false negative rate.
One of the things I'm asking Alberta Health Services is in advance is if one of my high spinal cord injury patients or neuromuscular patients who are completely dependent on their caregiver for everything will be allowed to bring in at least one caregiver with them to be their hands, eyes, and mouth advocate, in the same way that the hospitals that don't allow anyone will make exception for someone who's in labor, someone who is actively dying, or someone who's under the age of 18, because those people are dependent.
And I think that's correct. I think if when it comes to it, I would doubt whether the caregiver would be absolutely turned away. Visitors and things like that, a bit different. But I think you could make a case for the caregiver being allowed. And we do, as you said, we do make exceptions to this. So it's again, it hasn't been tested. It's hard to know exactly how this is going to play out.
Exactly, and that's why I'm raising the issue in advance and putting it on the radar of the healthcare system.
So one thing moving forward then to address part of this is this balance between whether or not a person chooses to go into the hospital or doesn't, and then also to find out what resources are available in their local jurisdiction if they do choose not to go into the hospital in order to provide oxygen support or other things in the community, and then also to be clear as to what they might do once they do go into the hospital if they choose to do so. So for moving forward across Canada, these things might be different, but as individuals living in these different communities, we might want to look around and see what the resources are available under those circumstances.
And that might be sort of specific in terms of what we would recommend is that we might generate a list of specific questions for your primary advocates. I mean, I think as physicians in this, we need to be advocates for our patients and try and get the best for them in the current climate, and that's going to change based on a variety of factors, but we can still sort of help and advocate.
Thank you. So if I were to summarize this, and I don't know if I can, but I think basically what we've discussed is that the risk to catching COVID is based on exposure, and that probably isn't different whether or not you have a spinal cord injury or you don't. There might be a decreased risk if you're a higher level injury and you don't touch your face, but there might be increased risk in terms of using your hands. If you're touching your wheelchair, you have to make sure you're very careful on cleaning your wheelchair. Any surfaces that you touch, make sure you don't touch your face. If you have a caregiver, make sure that the cleanliness and the steps that were taken that you guys described very well are maintained very carefully over the next while. The majority of people with a spinal cord injury and or not are unlikely to develop serious complications, and that we need to make sure that we're taking care of our symptoms and using Tylenol, having lots of fluids, managing those aches, and trying to manage the situation so that we don't end up needing to go into the hospital. And then and all of us need to think right now, going forward, what would we like to do depending on what level of disease we end up with, and that these things shouldn't be left to be decided at the last minute, that we should have some idea of what we want, whether or not we want to go to the ER, finding out what supports are available in the community, and then moving forward based on that. That's a pretty general summary, but it sort of, I think, talks to some of the main points that we raised.
I think things have to be general. It's very hard to be precise about this. There's going to be geographic variation. There's going to be, hospital variation, and, depending on who your doctor is and things like that will all make each situation has to be treated individually, I think, and try and come up with the best plan given your environment, for lack of a better term.
And I think that was an excellent summary, Chris. I think one of the other most important things is know who to call if you have a question or a concern or a problem. Who do you call? And have everything written out and documented. What your wishes are, who speaks for you, all the contacts. And meanwhile, stay safe and healthy.
Thank you, everyone. That was actually extremely informative, and I think it really puts a balance on the different things that we need to think about and some of the issues that have been identified that require more thought. And also, it highlights the need for people to look at what's in place in the different jurisdictions. So thank you, everyone.
Perfect.